Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am professor of pediatrics at the Icahn School of Medicine at Mount Sinai here in New York City. Thank you very much for joining me for this 306th episode of the podcast. I hope everybody enjoyed last week's episode on the topic of intracardiac echocardiography assisting in the performance of ablation in children as well as those with congenital heart disease. We spoke with Dr. Thomas Pilcher, who's the Director of Electrophysiology at Primary Children's Hospital, and for those of you with an interest in electrophysiology or intracardiac echo, I'd recommend you take a listen to last week's 305th episode. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. This week, we move on to the world of Ebstein's anomaly, looking at an unusual aspect of it. The title of the work is Assessing Left Ventricular Pathology in Patients with Ebstein's Anomaly Using Cardiovascular Magnetic Resonance, Looking Past the Right Heart. The first author of this work is Aditi Gupta, and the senior author is Adam Christopher, and the authors come to us from the Division of Pediatric Cardiology at the Heart Institute at UPMC Children's Hospital of Pittsburgh in Pittsburgh, Pennsylvania. When we're done reviewing this paper, Dr. Gupta has kindly agreed to speak with us about it. Therefore, let's move straight on to the paper and learn a little bit about the left ventricle in Ebstein's anomaly. This week's work begins with some general comments about Ebstein's anomaly, reviewing how it was first described over 150 years ago in 1866, and how rare this condition is, affecting less than 1% of congenital heart patients. They review the key features of Ebstein's, including the tricuspid valve dilation, apical displacement of the septal and posterior leaflets, and failure of delamination of these leaflets, leading to progressive tricuspid regurgitation, RA dilation, and RV enlargement with dysfunction. The authors make the point that though we traditionally think of the right heart as being the affected portion of the heart in Ebstein's patients, the LV has been demonstrated in multiple small studies to also be at risk for disease, and some of the abnormalities that have been described have included LV hypertrabeculation or non-compaction cardiomyopathy, or even LV dysfunction, which the authors suggest has been demonstrated in prior works in anywhere between 7 and 50% of Ebstein's patients. They explain that the mechanism for LV dysfunction in this patient group isn't known, and prior works looking at LV non-compaction in this disease have been limited by echo image quality. As we all know, the De Silva Ebstein Center at UPMC is known for excellence in this operation, and so they have a fairly large number of referrals of Ebstein's patients coming to Pittsburgh for the De Silva cone operation. But there is thus far limited data on pre-op LV morphology and function in this group. And so with this as a background, the authors aimed to, quote, evaluate the prevalence of hypertrabeculation LV non-compaction and preoperative LV dysfunction amongst a heterogeneous population of referrals to the De Silva Center for Ebstein's Anomaly and correlate these to right ventricular parameters and perioperative care. The authors described the study group as 47 patients who underwent a De Silva cone procedure at the University of Pittsburgh Medical Center from 2016 to 2024 and who also had a CMR preoperatively. They also describe an 11-patient control arm. They review the echoes that were performed on all patients using standard echo machines described by the authors, and they also review how CMR studies were performed all on 1.5 Tesla machines, which were either a Siemens or GE machine. All studies included standard steady-state free precession, or SSFP short-axis stacks, as well as 4-chamber or axial SSFP stacks, through the LV to accurately assess preoperative size and function. They also explained that for the RV, the atrialized RV and functional RV were contoured separately, and functional RV was used in the results. The authors also reviewed the displacement index and how it was determined on the CMR, and also how they measured a non-compacted to compacted ratio, measuring it in the diastolic phase of the short-axis cine SSFP, with LV non-compaction being defined as a non-compacted to compacted ratio greater than or equal to 2.3. They review how they measured LV strain on CMR using the Circle CVI 42 software to obtain peak global longitudinal and circumferential strain values. Lots of basic demographic data and diagnostic and historical data on the patients were obtained, as well as cross-clamp and cardiopulmonary bypass time, length of hospital and ICU stay, as well as duration of postoperative milrinone and epinephrine use. And on to the results. So again, we're speaking of 47 total CMR Ebstein's patients and 11 controls. The mean age was 21 years. 2 patients of the 47 had mild LV dysfunction on echocardiography that was also confirmed on CMR. However, importantly, the CMRs demonstrated that 18 patients of the 47, or 36%, actually had mild preoperative LV dysfunction on CMR, with one having moderate dysfunction. But remember, only 2 patients actually had mild dysfunction seen on echo. So again, the CMR identified fully 16 patients with dysfunction that were passed on by the echo as being normal. Amongst those 18 Ebstein's patients with depressed ejection fraction on the CMR, the global circumferential and longitudinal strain were similarly lower compared to the Ebstein patients who had a normal EF, negative 14.8% versus negative 17%, respectively. And what about LV non-compaction? Well, it turns out in this series, only 1 patient met the criteria on CMR for this diagnosis, and there were no statistical differences between the Ebstein's and non-Ebstein's control arm. Interestingly, using multivariable linear regression analysis adjusting for age, the authors found that LVEF had a significant negative correlation with both the tricuspid valve displacement index and also RV end-diastolic volume, suggesting that more severe forms of Ebstein's anomaly were associated with worse LV parameters of function. And how did any of these measures of CMR correlate with perioperative outcomes? Well, LV dysfunction on the CMR had no impact on cardiopulmonary or aortic cross-clamp times, or even duration of milrinone after surgery, between those with and without LV dysfunction undergoing the cone procedure. Interestingly, there was a significantly longer use of epinephrine in the post-op period for those who had preoperative LV dysfunction on the CMR, 34 hours of epi exposure versus 10 hours, and that difference was significant. When the authors looked at length of ICU and hospitalization, both were longer in the LV dysfunction group. The ICU stay was roughly 1 day longer in those who had pre-op LV dysfunction, 3.1 days versus 2 days, and the hospital length of stay was also longer at 6.3 days versus 4.4 days for those without LV dysfunction. In their discussion, the authors state, and I quote, "Our findings revealed that LV dysfunction was common in preoperative Ebstein's anomaly patients, 36%, which is consistent with prior literature. Many cases exhibited reduced LV ejection fraction, likely due to RV dilation, paradoxical septal motion, and ventricular interdependence, which is consistent with prior studies." They discuss how LV non-compaction's prevalence in Ebstein's has been reported to be between 5 and nearly 30%, and how this is not similar to their data set, and they wonder if that is based on echo having been used in prior works rather than CMR, which they suggest is less accurate. The authors then speak about why it might be that the echoes in this work only identify 2 of 18 patients who were determined on CMR to have dysfunction, and they suggest that this highlights the difficulty of LV quantitative assessment of function with a dyskinetic septum as is seen in Ebstein's anomaly, and explain that compression of the LV by a dilated RV has been posited by some to explain the LV dysfunction that's seen in Ebstein's. And they also recall how other literature suggesting a propensity towards myocardial fibrosis in the LV of Ebstein's patients may also explain this difference. The authors reemphasize how these pre-op LV dysfunction findings were associated with longer use of epinephrine postoperatively, and how this has demonstrated a significant correlation with postoperative course. In regards to limitations, the authors point to the retrospective nature of this work, the variable timing of the CMR relative to the surgery with some patients as much as 2 years prior, the use of some outside CMRs, the lack of long-term follow-up data given that many of these patients came from very far to have surgery in Pittsburgh, and the small cohort size. And so they conclude, true LV non-compaction is rare in this patient population. Preoperative LV dysfunction is fairly common, and there is negative correlation of LV function with right heart volume and tricuspid valve displacement index, all markers of Ebstein's anomaly disease severity. No correlation was found between the degree of LV trabeculation and LV dysfunction. However, the presence of LV dysfunction is under-recognized by echocardiogram as compared to CMR, and quality pre-operative CMR assessment of the LV is relevant to perioperative management of Ebstein's anomaly. Further studies with a long-term follow-up are necessary. Well, this is an intriguing study in that it upends the notion of LV non-compaction being very common in Ebstein's patients. It's also perhaps a bit worrisome that so many patients passed their echo with normal reported LV parameters of function, but then had an abnormal CMR. This is something of interest to discuss with our guest. I'm also interested to know if those with LV dysfunction had normalization or improvement with follow-up following the cone operation, and also if any patients who had normal pre-op LV function actually developed dysfunction following surgery. Thus, with these questions in mind, I think it would make sense to move on to speak with the work's author for some clarification and discussion. Joining us now to discuss this week's work is Dr. Aditi Gupta. Dr. Gupta is currently the Advanced Imaging Fellow at the University of Pittsburgh Medical Center, Children's Hospital of Pittsburgh. She received her medical training in Maulana Azad Medical College in Delhi, India, followed by residency in pediatrics at Lincoln Medical Center here in New York City. Following that, she completed her general pediatric cardiology fellowship at UPMC Children's Hospital of Pittsburgh. It is a delight to welcome an up-and-coming superstar to the podcast. Welcome, Dr. Gupta, to Pediheart. All right, I'm here now with Dr. Aditi Gupta. Dr. Gupta, thanks so much for making some time to join us this week on the podcast.
Super excited. Thank you for the invitation, Dr. Pass.
Great pleasure to have you. Thank you. Very much enjoyed this work. Very interesting idea to look at the LV in Ebstein, something we don't often think about. Your work reports on 47 patients in the study time period who had a cone procedure for Ebstein's and who had a CMR. And I wondered as I read this if your center routinely performs CMRs like this before the cone all the time who are going to have the operation, or was there something that was more concerning about the particular patients that you included or that had CMRs? Have the results of this work changed your approach to preoperative CMR for this diagnosis and surgery?
Yes. So this was a practice change like around 2021 where we started routinely performing CMRs as a part of preoperative assessment for all the cone procedure. As the Silvas who do all the surgeries for the cone procedure joined the center in 2016 and the number of cases increased, it was realized that not only there is a wide variety of tricuspid valve morphologies, but also of the right atrial size and the right ventricular size and shape, which is totally not accounted for by the echocardiography. And also, like the valve results are very, very good in terms of reduction in the tricuspid regurg and the regurgitant fraction. But what needs to be monitored over time is the RV size as well as RV function, which echo is definitely not a good tool. It is very based on visual assessment, which is very inter-observer dependent. Therefore, CMR gives us more objective assessment of RV size and function, which can be trended over longer term. So it was just incorporated as a part of routine pre-op surveillance. It's still not like perfect, like not all the patients get it, but we try and get all as much of patients as we can.
I see. Very interesting. Thank you for that, and probably good practice to have an MRI in everybody preoperatively. You know, your work demonstrated that despite only 2 out of the 47 patients having any dysfunction of their LV on the pre-op echo, I found it interesting that fully 18 patients had CMR-defined dysfunction. In other words, the echo undervalued or undercaught dysfunction. Why would there be such a disparity? And I guess my question for you is, which test is right? Is the echo right in this case, or is it the CMR?
Yeah, so I quote a study by Dr. Fromeld, which looked at LV function assessment by echo in healthy pediatric patients. And they had said like the shortening fraction in EF can be like underreported even in healthy pediatric patients by 17% by blinded observers. So that was for the normal cohort. But looking at the Ebsteins, and especially in our cohort, which is all severe Ebsteins who met the criteria for surgery, all of them have severe atrialized RV, severe tricuspid valve regurgitation. There's a lot of paradoxical septal motion. And this dyskinetic septal motion makes the assessment of LVEF by the bullet method or biplane by which are the standard methods of assessment of EF by echo almost impossible. Also, most of these patients have cardiomegaly, which alters the heart axis, and we might not be able to get the standard echo views that we are used to measuring the bullet method. So CMR definitely is the gold standard for volumetric assessment as well as assessment of ejection fraction. And it has definitely added value for both RV and LV function objective parameter, and especially in this lesion where the septum does its own thing.
I see. Very interesting. Aditi, LV non-compaction seems to be reported as being more prevalent in Ebstein's in other works on Ebstein's than you report in this particular work. And I wondered if you had any thoughts on why, in your study, LV non-compaction was substantially rarer than in other reports of Ebstein's patients.
So we used the Peterson criteria, which is a 2D based criteria, which is definitely not a perfect criteria, but the most commonly reported criteria to define LV non-compaction by CMR. So all these studies were looked by two senior imagers, and everybody agreed that there was only one patient who met the criteria of LV non-compaction. There were a few patients who had some prominent trabeculations, but definitely did not meet the non-compaction. So we were pretty convinced about the data we put out that it is not that common. And also speaking to the surgeons as well as senior cardiologists who have been taking care of Ebstein patients in our center for almost a decade now, they all believe that LV non-compaction is not that common as has been commonly reported, at least in our experience in our center. Everybody agrees that they've hardly seen a non-compaction with Ebstein's, even though it is so commonly reported.
Interesting. Your work demonstrated very interestingly that longer hospital stay, ICU stay, and use of epinephrine was seen amongst patients who had preoperative LV dysfunction. Aside from allowing for better anticipatory guidance to families regarding expectations in the post-op period, do you think that this information can practically inform ICU management to improve the care of these children after surgery?
So hopefully it will eventually. For now, most of these patients who underwent cone procedure have very quick recovery and have very excellent perioperative or like immediate post-op outcomes. So what our ICU physicians have traditionally looked for is like if there is severe dysfunction, which is mostly the severe RV dysfunction, they're more cautious about weaning inotropes. But this mild to moderate LV dysfunction, which is being picked up on CMR, is definitely a new territory. But as our experience and as our referral base grows, we might be able to streamline it more and inculcate it more in our ICU. But it's definitely a new territory. We've not made any changes for now with this study and the results.
Sure. Well, for those in the audience, Dr. Gupta was nice enough to join us late on a Tuesday night before the release of this podcast on Friday. So I'm going to wrap this up with one last question, and that was, are there any plans to restudy these patients after repair to see if there are any positive impacts on LV function parameters? It's pretty common to use CMR to follow the RV and the tricuspid valve after a cone, but are you going to see what happens? Like I was wondering, for example, if there was less LV dysfunction after a good repair, or if perhaps surprisingly there was more. So I'm wondering if you're planning to look at these patients later.
So yes, that is the goal, to have this objective data pre-op so that it can be looked at post-operatively. We did have a smaller number echo-based study which looked at LV parameters just because it's so hard to get a post-op CMR since it's a referral center with like variety of local resources that patients come from. In that smaller study, we did find improvement in LV stroke volumes, but not changes in the EF, which we now makes sense that because probably LV EF was never picked up by echo in the first place.
Yes.
There was another study by the Great Ormond Street group, which was discussed at your podcast too, which they looked at pre-op and post-op CMR, LV function. But that's the goal. But I think all these studies are constrained by smaller numbers just because of the International Referral Center. And it's just hard to get a post-op CMR and long-term follow-up. Yeah. We're trying to find more solid base so that it can be done at the local center and they can send us the imaging. But it's definitely hard and it will take time.
Yeah, and I imagine for a center such as yours, where so many people are referred in from all over the world, it's particularly difficult to get those follow-up studies, I'm sure.
Yep.
Well, Dr. Gupta, I can't thank you enough for joining us. Always wonderful to have an up-and-coming superstar on Pediheart. Congratulations to you and all of the many co-authors of your work, and thank you so much for joining us this week.
Thank you, Dr. Pask.
Great pleasure.
Well, I think you'll agree that Dr. Gupta provided us with a lot of insights into the left ventricle in patients with Ebstein's anomaly. She was an uncommonly clear speaker, and so I don't really think there's a whole lot to add. I certainly think the book hasn't been written completely on this topic, and certainly long-term follow-up of the LV following cone repair is going to be a very interesting topic to keep track of into the future. Once again, I'd like to thank Dr. Gupta for taking time out of her very busy schedule as an advanced imaging fellow in Pittsburgh to speak with us this week on the podcast. To conclude this 306th episode of Pediheart Pediatric Cardiology Today, we go back over 70 years to once more hear the magnificent, preeminent dramatic soprano of the 20th century. I'm speaking of the American Greek soprano born Maria Anna Cecilia Sophia Kalogeropoulos, but now better known as Maria Callas. Today we hear her sing the powerful aria Suicidio from Ponchielli's La Gioconda. The lyrics of this aria, sung by the character La Gioconda, reflect a moment of intense emotional turmoil and contemplation of suicide as an escape from her suffering. Thank you very much for joining me for this 306th episode, and thanks once again to our guest. I hope all have a good week ahead.
Aditi